All right, this is Dr. R, and we're back here at a epidemiology question. So first thing I'm going to ask you to do is to take time and hit pause and look at the question lead-in and stem, and then try to answer the question using these question answer choices and write down why and why they are not correct or they are correct. All right. Okay, so let's cover the question lead-in. This statement by the pharmacy company is most likely the result of which of the following types of bias? So we're going to be looking at bias, and we're definitely going to have to go back to the question stem, and this is quite the question stem. So let's look at the answer choices. We have expectancy bias. Hopefully you know what that is. That's very focused on the researcher themselves. We have lead time bias, which we'll discuss and get into. Measurement bias, proficiency, and sampling. So these are all biases that are possible in research studies. To answer a government-issued request for proposal, which is an RFP, a new screening drug, so we have a new drug, or screening test, for pancreatic cancer. So we have a new screening test for pancreatic cancer. It was developed by a company. This new test was intended for use in high-risk populations. I don't know if that's important, but that sounds good. To demonstrate the efficacy of the new test, the company conducted a cohort study. Okay, so they conducted a cohort study, meaning that over a period of time, they started with nobody not necessarily having the disease, so no disease, and then they followed them over time, and then they probably ended up getting the disease at some point, some of them, and these people ended up becoming the numerator, right, the new cases, and then the people that were at risk of getting the disease were in the denominator, and that was those at risk, the population at risk. Okay, and then that is called what? That is called incidence, right? Because that's what we do in cohort studies. All right, so a cohort study following a population of African American men with a history of smoking cigarettes. So these were the at-risk individuals, and this was a long cohort study. So this cohort study was for 15 years, and so it looks like these people were at risk and they were smokers. Each year, individuals were tested for pancreatic cancer using the new test. So they were tested for pancreatic cancer using the new test, as well as a widely used CA19-9 blood test, which is just the gold standard test. So let's just call it the gold standard test, or the existing test. We don't have to know anything about CA19-9 or any of that. We just need to know that there is a new test comparing it to a pre-existing test. And then they did confirmatory testing using ultrasound, CT. So then they did imaging to look at the pancreas for pancreatic cancer. So CT were completed as necessary. The results showed that pancreatic cancer was detected an average of 6 months earlier. So that's good, especially given what the survival rate is with pancreatic cancer. So that means that the old test, or the gold standard test, was here, whatever date that is, and the new test came in at 6 months earlier, diagnosing people. That's great. The results show the pancreatic cancer 6 months earlier using the new screening test than it would have been using the CA19-9. To promote these results, the pharmaceutical company produced an advertising campaign saying that this new test extended life of the cancer patients by 6 months. Does it extend life? If we detect something 6 months earlier, does it mean that people survive longer? Well, one might think so, but, so for instance, if you look at imaging, let's say we are going to use CT, right? Or ultrasound. Well, CT and ultrasound, if you're looking at the pancreas, it's usually in the head of the pancreas where this stuff happens. So if you look at that, if there are tiny little cells here, and we use an ultrasound or a CT, we might not pick that up. But let's say we come out with some new kind of imaging, and the new imaging is able to pick up smaller and smaller pieces. Therefore, before it grows to a larger tumor, where ultrasound and CT can pick it up, we're picking it up sooner as a smaller tumor. So that might be equivalent to this, right? So instead of a blood test or a screening blood test, we are now looking at imaging, and this would be CT and ultrasound, but yet our new kind of imaging picks it up 6 months earlier because it's able to see a smaller tumor. But does detecting a smaller tumor actually means that you increase survival? That is not true. So, to me, this is starting to sound like what they call lead time bias. So, lead time bias means that we start saying, or someone says, that because we detect something sooner, earlier, we increase survival, and that is not the case. So this might be lead time bias. So the lead time means that we are ahead of where we were before, does not necessarily mean an increase in survival. But let's go over the answer choices now. Expectancy bias. So expectancy bias is actually a bias that the observer puts out. So as a researcher, I might consciously or unconsciously influence the participants or the results of the experiment. And this can be done many different ways. I can design the study in a single way that might introduce a type of bias. I might think that this increases survival, therefore I'm designing the research study that will prove out that it increases survival. And that is not necessarily the case. So I'm always having to check myself through expectancy bias. And how I do that is oftentimes we will blind both observers or researchers and patients or participants. This is a double blind. If we only blind the participants, that is a single blind. And the researchers stay unblinded, that is a problem. We can then initiate expectancy bias. So we like to do double blinding, and that helps eliminate expectancy bias. But are we talking about expectancy bias here? No, we are not. Oh, there's lead time bias. So this I actually like as an answer. So we'll keep that there. Measurement bias. Excuse me, measurement bias. So measurement bias has to do with the measurements themselves that we're actually getting. So for instance, imagine you're in a doctor's office and they have a sphygmomanometer in each room. And what if the sphygmomanometer or blood pressure cuff in A was off compared to B and C, D, E, and F? So for some reason, A was not calibrated correctly, B was calibrated correctly, and so was C. But what if all of these had different calibrations? Then we would be measuring blood pressures and introducing a measurement bias. But that's not what we're talking here, so that is definitely not the answer choice. So proficiency bias might occur if the skill levels of those that are either administering tests or interpreting tests. So for instance, what if you went and took blood from a patient, but you actually left saline solution inside the syringe when you went to pull out the blood? You might have a proficiency issue in how you actually extract blood or extract a test or conduct a test. So this has to do with the people that are doing the tests or the people that are in as a part of the study themselves. So proficiency bias does not relate to what we are talking about here. And then finally, what about sampling bias? So sampling bias is when we are talking about having a non-representative sample. And we talked about this before when we were talking about probabilistic versus non-probabilistic, right? So probabilistic has to do with putting people in groups by chance, right? Whether they are experimental or they are the control group, or putting them in there with no chance, and we actually put them in an experimental and a control group, and we have, as a researcher, control over this. Okay? So that's not what's happening here. So in my mind, lead time bias is the most correct answer, and it actually fits what we were talking about in relation to this question. I hope you agree.